Okay. Welcome you all. My name is Tashi Jacobs. I'm the OEF program coordinator at Black Health. And this is part one of our obesity webinar series. We'll have this in 4 parts. Just a little bit about Black Health. So Black Health is formally National Black Leadership Commission on AIDS since 1987. And in 2019, we made the transition over to National Black Leadership Commission on Health. We rebranded to not just deal with HIV/AIDS, but also to include other health issues that affect our community, like hepatitis, heart disease, breast cancer, prostate, sickle cell, diabetes, mental health. And in that, we have expanded, and now we talk about so many other hot topics in our community. One of them is obesity, and we have Dr. Sylvia, who helps us greatly in that avenue. And she brought these other beautiful doctors here to talk to us about obesity in this first part, with obesity being a medical disease. And I am going to hand it over to Dr. Sylvia, and she'll be your host for this series.
Hello and welcome everyone tonight. I am so excited. Tashi and I and the Black Health team, we have been planning for months for this very day. And when they asked me to come on board and help them, I was like, I'll come, but only under one condition, that we do not talk about obesity the same old boring, played out way that doesn't get impact. So we have really put together content that we want to be transformative, that we want to help you. As you can see, look, I'm like, it's like FUBU, for us, by us, right? Because we want this to be we are working with Black Health to help improve Black health, especially when it comes to obesity, because we have the highest rates. Black women have the highest rates of overweight and obesity. 4 out of 5 Black women in particular. And Black men, don't think you're off the hook. About 1/3 of you have obesity as well. So when these numbers are really high, and it's not just a cosmetic issue, it's really not, because we all look good in the skin that we're in and the body we're in, but it is really a health issue, and it's about improving our health outcomes. And it's about, now that we have survived the pandemic, really helping us thrive and live our best lives after the pandemic. So it is my esteemed honor to be here tonight and to present to you 2 of my dear colleagues and friends. These women are pioneers in the field of obesity medicine. And I feel like the world needs to know who they are. And so I am truly grateful that they have agreed to come on tonight and to share with you. But I really encourage you, even though the chat is not working, oh yes, and it looks like we do have the chat maybe working out. So please add your comments in the Q&A box, add your questions, add your comments. We want this to be interactive. We are truly here for you tonight. We're here for you because it means nothing if we just talk about statistics, but it doesn't impact the people whose lives we want to reach. So please let this be a time of honesty, a time of openness. We just ask that everyone do be respectful of other people as well. And so that's the only thing, but please be open and honest. And so without further ado, I'd like to introduce these 2 lovely women here today. Dr. Daphane Bryan is the 3rd of 4 children. And I love that she starts with that. And she spent her formative years in Dover, Delaware. But she graduated from high school in Petersburg High School after her family moved to Virginia. She completed her BS in chemistry at Howard University, HU. Even I know I had to do that, right? And she attended medical school at the Medical College of Virginia. She practiced family medicine as her specialty. And after completing her training, she returned back to Howard University, her alma mater, and taught there for several years. She then moved back to Richmond, where she took a position at VCU, Virginia Commonwealth University Health System. And she became the medical director and kept that position for 19 years. And while there in that position, serving in the community, she developed her interest in obesity and nutrition. And she went on to become the first, I told you she's a pioneer, the first physician in Richmond to be board certified in bariatric medicine. So she's currently a board certified in family medicine and bariatric medicine, which we also call obesity medicine for those who aren't familiar with that. And then she works at the Gonsahn-Bollie's health system in Chesterfield. She works at their weight management system, but she's also the CEO of Mana Health. And I can't wait for her to share a little bit about that too when she talks. And she's the mother of one son, a Johnny, a very talented young man. And she currently resides in Moseley, Virginia. So thank you so much, Dr. Daphane Bryan, for being here tonight.
Thank you. I appreciate your invitation. This is my pleasure.
We can't wait to hear you speak. And then I'll introduce our second speaker, who is Dr. Joynita Nicholson. Look, she's looking so fat. Both of these ladies are looking so lovely. I can't help but comment. So Dr. Nicholson didn't put it on here, but she was the former Miss Elizabeth City. So I feel she's looking very pageant-y tonight. Yes. So she is an award-winning, passionate bariatric medicine physician who received her medical degree and her academic leadership fellowship from Ohio Heritage College of Osteopathic Medicine. And I would love if she can share a little bit with you all about what that is and the difference, because that's also an important tool for us to know. And she's a board certified in obesity medicine and family medicine and osteopathic manipulative treatment. She is no stranger to breaking down barriers, as she has patiently pioneered a 10-year bureaucratic process to integrate obesity medicine into patient care in her healthcare market, culminating into the opening of the first centralized Bon Secours St. Mary Wellness Weight Management Center in Richmond, Virginia, combining medical and surgical services, where she serves as the first obesity medicine director. For years, she has been a strong voice for patients with obesity, even at high levels, in her role in the first OMA, which is the Obesity Medicine Association, state advocacy representative for Virginia. For over 20 years, she has compassionately partnered with her patients, providing them with preventative, high-quality, comprehensive care, while enthusiastically empowering them with evidence-based knowledge. So we are so honored to have her here to improve their weight, their overall health and well-being, while yielding life-changing results. During her free time, Dr. Nicholson enjoys traveling across the country by airplane, radio waves, virtually, and an invited, accomplished, well-received, motivational, and informative public speaker who, with great joy, educates her audiences about obesity-related health topics in impactful ways. And she's the mother of 3 very talented boys and the wife of Lorenzo and a leader in her community, in her church. And it is just such an honor to have you here, Dr. Nicholson, as well. Oh, you're on mute. If you'll unmute.
Thank you so much. We changed the settings there. It's such a pleasure. I appreciate the invitation and look so forward to meeting our viewers and collaborating this evening about this wonderful topic.
Wonderful, wonderful. Yes, and I see we already have some fantastic people here. We have Dr. Angela Clack, who will also be a speaker in our personalized session, personalized Black women, an obesity session. We have Loretta Mines, we have Shahida and Denise Bolsa. Welcome, welcome everyone. Again, you all, this is your session. Please put your questions, your comments in the chats as we go in, and we'll be interactive as well. So without further ado, Dr. Nicholson, Dr. Daphne, we'll let you go ahead and get started, and I'll hang out in the background more as a moderator just to help along with the questions and comments.
Wonderful.
I'm sorry, before we get started, I need to run this poll really quickly. If you all, I'm going to launch this poll. The question says, BMI is a way to tell if you're overweight, yes or no? We'd like the participants to answer that. And if you can't see the poll, go ahead and let me know in the Q&A. Okay, take another moment. All right. So, okay. 80% of you say that that's true, and 20% of you say that it's false. Another question. How would you define the quality of efforts to support healthy eating and physical activity in your community? Would you say very good, good, acceptable, poor, or very poor? And these polls are just something to help Black Health kind of get an understanding of where you all are. And perhaps with the information that you'll learn today, you'll be more informed, or maybe you all already know, especially pertaining to BMI. Right. So 4% of you say that it's good. 48% of you said that it's acceptable. 40% of you say that it's poor, and 8% say very poor. Right, last one. This one is about nutrition. How often do you read nutrition labels? Or if you don't do the shopping, right? Whomever it is that does the shopping for your household, you'll know if they read nutrition labels because they'll likely talk about it. Okay. Couple more seconds so that we can get into the presentation. All right. So 11% of you say always. 56% of you say very often. 19% of you say sometimes. 11% rarely, and 4% never. Okay. I think with me, it depends, but they started saying stuff about Skittles now. I try to pretend like I don't see those, those facts. All right. Thank you all for participating in the poll. And doctors, please continue.
All right, wonderful. And I saw some questions in the chat already. Like I said, I'll be manning them. Someone asked, what is BMI, body mass index? We'll go more in depth about that in the presentation. And yes. Oh, great. And then we have some other physicians here, an OBGYN and at the ground level. So this is so wonderful. Have a great group, continue the dialogue, and I'll be checking throughout. And without further ado, I'll let Dr. Joynita Nicholson and Dr. Daphane Bryan get started.
Well, good evening. Such a wonderful pleasure to be here. Dr. Daphane Bryan and I have decided to really make tonight more of a conversation about the topic. We didn't want to come here preaching that this is so or presenting it in a debatable way. We just want to present information, food for thought, if you will. So we invite you to join into our conversation by, when we get to the purple slide, we're going to have about 4 purple slides here. Whenever you see the purple slide, it's going to be our time to ask Dr. Bollie to please share any questions you all might have entered into the Q&A section so that we can address them. But it's also to be our opportunity to ask you a question. So please have your pen and paper handy if you do not want to commit by sharing in the Q&A section of our presentation. But we're so excited to be here. We are the first part of a series of webinars, and Dr. Bollie will be moderating each of them. There are wonderful topics. Some of the answers to your questions from the poll that you were just given will be better addressed in each of these topics. So we invite you not just to tonight's webinar, but to return to the others as well. We do have
Excuse me, Joynita, are you sharing
I'm
your
not-
slides?
I'm not seeing
We can't see your
slides.
slides. And if not, I'm happy to share them.
Yes, would you mind sharing?
Okay, no problem. Mhm.
I
And-
apologize. I thought they were already on.
No problem. And then just tell me to when you need to change your slide, and we apologize for that technicality. So we'll just pull it up one second. I was like, you worked very hard on these slides. They need to see they're beautiful.
I have my son here. Go on, Ian. Okay. Is it easier this way?
All right, I have it. There we go. Okay, can everyone see the slides?
Okay, can we make it full screen? All right. Can everyone see now?
See.
Okay. All
There
right,
we
can
go.
you all? Okay, and I think it's coming from my screen, Joynita.
Okay, great.
Okay, all right, so just tell me when you want me to move and I will move them.
Next
Okay.
slide, please.
Okay.
So we're the first of a series of presentations that you will get even more information about the responses to the poll questions that you just answered. So stay tuned and we invite you to return. Next slide. We have a disclaimer. The presentation is for educational and informational purposes only, and the material expressed comes solely from our presenters, meaning Dr. Bryan and me, and they do not express the views of any other entity. Next slide.
Okay, so at the end of this presentation, the learner will understand obesity is a complex medical disease, not just a lifestyle choice. The multifactorial contributing factors to Black people having higher rates of obesity. We hope that you're going to understand that, and that the diagnosis of obesity, you will understand the diagnosis of obesity beyond just the body mass index or BMI that we mentioned a few minutes ago, as well as there are multiple treatment options for obesity beyond diet and exercise. You can change it.
We're at our first purple slide. And the question that we have is, well, first let me pause. Dr. Bollie, do we have any questions in the Q&A poll yet? I didn't think so, just a test drive here. But our first question is, obesity is a complex medical disease, not just a lifestyle choice. Is it A, true, B, false, or C, who cares, Doc? We'll give you just a moment to commit to your answer. And if you'll enter your answers in the Q&A, Dr. Bollie, I'd be interested in seeing what some are saying. A's, B's, C's. How's this going?
I'm getting so far all A's, all true. Yeah.
Oh, wow. All right. So the presentation is done, okay? Because this was nonetheless, we hope that there still is going to be at least one pearl or one significant moment that you have as we share information. Next slide, please. I'm glad you all care about this topic. So let's take a stroll down history lane. Would you believe that in the 1920s, the perception of obesity changed? Actually, thin was not in. Carrying an extra 20 to 50 pounds was a sign of being healthy, a sign of vitality and wealth even. The other significant thing that happened in the 1920s was this thing called BMI that you've already been introduced to, stands for Body Mass Index. And it was first expressed by Alfonso Quetelet in the 1800s. But it came about again in the 1920s when the Metropolitan Life Insurance Company wanted to define the average man by analyzing height and weight information of French and Scottish armies of that time. So if we think back to that time, were there any women there? Were there any other ethnicities represented? You know, were there any elderly or pediatrics represented? And that is where we also find some of the limitations might be. Next slide. In 1930, that's when the medical profession started saying what we still hear and some people still say today, and that is eat less, burn more calories. And if you do not achieve your desired results, then guess what is blamed? Laziness and undisciplined behavior. By 1950, obesity began to be studied more, and it was determined that it was a problem, but still debatable as a disease. And then by 2008, our research-oriented medical group called the Obesity Society discussed why obesity should become a disease. Next slide.
And then finally, the American Medical Association decided to make the statement that obesity, some of the characteristics of this disease, of a disease, is an impairment of the functioning of some aspect of the body, or this is how we define a disease. And it demonstrates characteristic signs and symptoms. And it also causes harm and morbidity.
So Dr. Bryan, they actually found that these three components were met when they started studying obesity, didn't they?
Right. And so then it took 60 years later, and finally in June of 2013, the American Medical Association made the statement that it recognized obesity as a disease with multiple pathophysiological aspects requiring a range of interventions to advance obesity treatment and prevention.
Next slide, please. And it's time for your questions. Any
More
questions?
questions?
If not, we'll proceed with ours. Do we have any, Dr. Bollie?
No, not yet, but I think people are still shocked that it was 2013. So it hasn't even been 10 years that obesity is recognized as a disease by the Medical Association, American Medical Association. So that's very shocking. So I think they're still in shock by that. So you can go out with the purple slide.
And can you appreciate how long it took? You know, they started studying it many years ago, and then here 60 years later, it's almost the same story that we're going to hear in a few minutes when we start to talk about medications and how they've been approved. It's when it comes to the disease of obesity, it's a very slow process. And that's because some people in these positions of decision still are not convinced it's a disease. They totally blame the individual and say they did it to themselves. You know, if they just put that fork down, push back from the table, then they won't have this disease. Or they don't even call it a disease. They won't have excess weight. right? But hopefully, as we share more information this evening, you'll have more grounds to have a very firm position and hopefully understand that, you know, it does satisfy those three things that the American Medical Association used to define disease. So
Exactly.
it's what it is, you know, it's a disease. Now let's move forward with what do we do about it? All right, so question 2 is, what is obesity? Is it a common, serious, and costly disease? B, a complex disease that occurs when a person has excess body fat. C, a chronic, relapsing, multifactorial neurobehavioral disease. Or D, all of the above. We'll give you just a moment because these are a little bit longer, so really think about them. And as many of you probably know, with multiple choice questions, you've got to choose the best answer. How are we looking, Dr. Bollie?
Oh, we got a little drama here. I'm here for it. So, so the majority is D, all of the above, but we have B is a very popular answer as well. And then Dr. Jenny said, is there a push for tailoring the BMI charts to be more culturally sensitive? And you will hear more about that later on. So sit tight because we will talk about that. So yeah, so B and D seem to be the most common.
And the best of the two answers is D, all of the above. So in the next series of slides, we hope that you will have better understanding why each of these is important. Next slide, please. Great job. Let's start with the very first letter. Back one slide. When we talk about, is it common? You know, is it serious and costly? Well, according to people who have the disease, and maybe even some who are trying to prevent the disease, you know, my patients oftentimes say it costs me more money to try to be healthy. You know, the food costs a lot of money, the gyms cost money. You know, when I try to buy my own equipment, that costs money. You know, I'm trying to buy bottled water or whatever the system might be, that's money. My personal trainer, my coaches, it costs me a lot of money. So I don't know what the United States has to pay by the time I pay everything. But I'll tell you, based upon the information that's available, the United States says it's very expensive for Americans to have obesity. And why is that? It's because, you know, the cost of healthcare is higher, right? Because obesity is associated with other medical conditions such as diabetes, cardiovascular disease, asthma, arthritis, cancers. And so by the time you also have to cover the cost of the associated health conditions, that the cost for healthcare increases. And then if you have to work, what happens? If you have an asthma attack or if sugar is way out of control and you have to be hospitalized, you know, you lose days of work, right? So lost work days, lower productivity. And in some instances, some people become permanently disabled. So then the employer has to pay for the disability as well as someone to do the work. And in some of the worst case scenarios, mortality, right? Because with obesity, life expectancy can decrease. So there's a higher cost for living, higher cost for health insurance, and a higher cost, for caring for patients who have obesity at times. And the last number that I found was 147 to 210 billion dollars per year is what the United States has to pay annually for patients who have obesity. The number was 177 for a while, kind of held steady. But once we've gone through COVID, it's gone up to even $210 billion. Next slide. And obesity does not discriminate. Take a minute and marinate over that, all right? It affects the young as well as the old. It affects males as well as females, as well as transgenders. It affects all ethnicities, right? And we even find that when it comes to children, 22% of the children and teens in the United States are affected by obesity. And this is up from pre-COVID, 19%. And now 25% of our young are even too heavy to join the military. So that creates yet other problems, right, in the United States if we can't have enough people to protect our country. About 42% of our adults have obesity, according to this study from the NHANES group, and that's even up from 30.5%, which was from 1999 to 2000. So obesity does not discriminate. It affects all ages, genders, ethnicities. Next slide, please. But obesity does affect some populations disproportionately. And we see that non-Hispanic Black adults have the highest rates of obesity in our country, followed by Hispanic adults, followed by non-Hispanic whites, and the least affected by obesity are non-Hispanic Asian adults. I did find one piece of information according to the Department of Health and Human Services Office of Minority Health, and this report was from 2015. I couldn't find anything more currently than that, but almost 33% of all American Indian and Alaska Native adults have obesity as well. So I thought that was important because this is also another population of patients that has been definitely impacted by obesity. Next slide. But across all age groups, the CDC crunched some new numbers on America's obesity epidemic, and I don't know how you feel, but I feel like this young lady in the picture. Women ranked number one. At one point, men had more obesity than women, but now women have more obesity than men. And African American women have the highest of them all, followed by Hispanic women. Next slide. So, if we can just pause for one moment, I know I've had patients who are African American when they come into the clinical setting. They say, Doc, I want to be healthy, but I want to keep my curves. I want to stay thick. My man likes me pleasingly plump. So I don't want to lose weight. I just want to get healthy, Doc. And I just want to challenge your thinking today and expand that even more to say, but if the thickness or the curviness or the pleasingly plump means that you have a higher body mass index and obesity, which in most cases, that can mean that the amount of fat in the body can exceed the amount of muscle mass. Now, in African Americans, we do find that there can be more muscle mass than fatty tissue. And I believe that some of our future webinars would talk more about that. But just wanted to kind of throw that out there. If you do have a higher body mass index and more fatty tissue than you have muscle tissue, then it can affect your overall health. It can affect your quality of health. Such as, can you fly in an airplane in one seat if you have a high body mass index? Can you ride roller coasters when your family goes to, the park? Or can you walk with your family without getting short-winded if you have excess weight? Can you go grocery shopping without pain? So these are all things that we think about when we think of quality of life. So having a higher body mass index, having obesity can impact those things. And it also can reduce your years of life. And that, that's the sad thing. So we're hoping today to really pique your thinking, pique your interest in learning more about, well, okay, if I have obesity, then how can I be the healthiest I can be? Here's another thought that came to mind, and just decided to make this a statement, and I can't wait to see what your thoughts are about it. But obesity is not your choice or your fault. It is your physiology. Now, hear me out, all right? So, when we think about choices, eating junk food versus healthy food, that's your choice, right? Having a sugar sweetened beverage, like your Diet Coke or your Pepsi or your coffee with 10 Splendas, that's your choice, right? Deciding whether or not you're going to drink water that day, deciding how much food you're going to eat in a meal, deciding how many meals you're going to have in your day. Those are your choices. Now, what's not your choice is once you make those choices, how does your body respond? How your body responds is what we refer to as your physiology. And that's what Dr. Bryan is going to discuss in the next slide.
I know this is a pretty busy slide, and I hope that I can just summarize it well enough for you to understand what we're trying to get across here. But we're just wanting to make the point that there are many, 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 many things inside and outside of the person that contributes to obesity, or what we mean by energy storage is when we eat too much, we're eating energy, or when we eat, we're filling our body with energy. And then when we have excess energy, the body has to do something with it. And so it stores it, and it stores it in fat cells. That's our way of handling excess energy. And then when we have too much, we have a problem. But some of the things that contribute to that, or examples are stresses like family conflict and different, stress is a big factor. That can be from family conflict, job conflict, so forth. Things like temperatures in your work environment and your home environment. Even things such as chemicals or things that we're exposed to in our environment, different toxins that we get exposed to. And inside the body, things such as night eating, or when we get up in the middle of the night, sometimes our sleep is interrupted by things like sleep apnea, so as an example. And when you wake up and then you get up and go eat something, that's a big factor that leads to obesity. Problems like things that affect your satiety, or delayed satiety, which means that you have more hunger or difficulty feeling satiated. Age-related things like, as we age, we lose some of our muscle mass, and when you lose your muscle mass, it also causes a slowing of your metabolism. Also, things that involve dysregulation of your endocrine system, such as thyroid dysfunction, those who have Cushing's disease or Cushing syndrome, or polycystic ovary syndrome. These all lead to things such as insulin resistance, and that dysregulates our bodies and how we manage or handle energy. Also, our gut microbia is a big issue, and how we manage or metabolize the things that we eat. There's so many different factors, and as you can see, this slide gives you kind of an idea of how many factors there are, and then this is just a little microcosm of all that's involved in obesity and the things that contribute to us storing energy.
Right. And I mean, even things like medications, right, Dr. Bryan?
Absolutely.
Medical
Medication.
conditions, because if our viewers think about it, some patients have had
Good point.
polycystic ovarian syndrome, they've had menopause, Cushing's disease, sleep apnea, pain. All of those things can contribute to how physically active a patient can be, but also, which goes back to their choice. Am I going to do any exercise today, or am I going to stay here because I hurt and just try to stay as still as possible?
Yeah.
Also things like medications, insulins, antipsychotic medications, medications.
Things that we take for depression and psychosis, those are really big players, as well as things that women take for fertility or infertility, to stop fertility, I should say.
Like Depo-Provera, is that what you?
Right, for
Yeah.
birth control.
Yeah.
Things like the Depo-Provera and the Mirena, which also is basically a similar form of birth control. There are those who argue that that's not the case, but I definitely see a huge, they have become a huge factor in weight gain.
And we're not saying stop your medicines,
Oh,
if
no.
they do contribute to weight gain. We're just saying have the awareness that when we talk about why people have excess weight or higher body mass indices, it's not just about the choices, right? It's about the medical conditions, it's about medications, it's about all these things. And the Obesity Society has summarized it as environmental, biological, maternal, economic, foods and beverages, psychological, and social. And so that's what this busy chart is all about. It's how those contribute to a person having excess weight.
Yeah, I like to, Rebecca Palmer's made a great comment in here. I think that Rebecca Penders, I'm sorry. She said, love that this connects mom's health, breastfeeding, delayed prenatal care, great connections here. And, I like to think about this as obesity triggers or weight gain triggers, and there's so many of them. And with women, those hormonal shifts, plus the psychological stress and this environmental factors, all of that is a major trigger for it
Yeah,
as well. So thank you, Rebecca, for adding that to the conversation.
Yes.
absolutely. Absolutely.
Next slide, please. All right. And so we added the COVID-19 pandemic slide because it's so real, right? What we've learned is COVID-19 was not included in that chart. It didn't exist in 2015. It came around in 2019. But it's worth mentioning because in a study that was performed by the American Psychological Association, 42% of our Americans gained an average of 29 pounds during the pandemic, and 10% gained more than 50 pounds. And some of these causes of weight gain were many people remember lockdown, y'all. Do you remember how scary lockdown was? It increased our anxieties and our stress, and some people started drinking more to deal with that stress. And some even started using marijuana because it became legal, remember, in some states, to help them sleep better and to deal with the stress. We didn't exercise as much. Why? Because the gyms closed and we were afraid. Somebody said at one point that the government was going to send militia in the neighborhoods. And so you needed to stay indoors at all times. We just didn't have understanding of the disease, understanding of how, we were going to handle the disease here in America. And so it contributed to increased stress, decreased physical activity, decreased socialization. Nobody was going anywhere to see family or anyone because we didn't know if we could give the disease or if we could get the disease. Food insecurity. Now, I know there was a toilet paper insecurity, but do y'all remember it was hard to find chicken in the stores? Oh
Sure.
my gosh.
Yeah.
And then they started limiting how many chickens you could buy at one point. Oh my God. And then wait a minute. Y'all remember the commercial where I think it was Wingstop, and I don't mean to pick on Wingstop, but they started selling thighs. Y'all remember that? So talk about, and I'm sure when people started seeing that, it started also worsening stress of, oh my goodness, are we running out of food?
Yeah.
So all of this contributed to weight gain, and it also caused some delay in medical care. Right. Next slide, please.
Yeah. So in this slide, I just want to stress the significance of how many medical conditions that are linked to obesity, and we're giving it over 236 medical diseases that are associated. Of course, this slide does not list all of them. I just wanted to point out a couple of things that have been especially important to me, or that I see sometimes people don't understand how these things connect to obesity. For example, sleep apnea. I see many times people don't recognize the signs and symptoms of sleep apnea, and that is linked to obesity. And when it's not treated, you frequently see people go on to develop atrial fibrillation, which is connected to obesity, because many times it's coming from the fact that people gain weight, develop sleep apnea because their neck is thicker and obstructing at night. That leads to problems in the heart muscle. They go on to develop AFib, heart failure, et cetera, et cetera, et cetera. Another important medical condition that sometimes gets missed is pseudotumor cerebri. What that is increased intracranial hypertension that happens, is directly linked to obesity. And that can present as headaches and blurred vision, and the headaches are many times diagnosed as migraines, and people are taking all of this migraine medicine. Headaches is not getting better, and it needs to be looked at, especially when a person presents with a headache and they are obese. We need to determine, is that going on? Is the pressure increased in their head? Also, some of the issues such as high blood pressure, blood clots. You see more, as I mentioned, heart disease, as well as high cholesterol. All of these things culminating into metabolic syndrome, which leads to more heart attacks and strokes, et cetera, et cetera. Type 2 diabetes, Premature puberty in the young also linked to being obese in the pediatric population. Cancers, many cancers are also associated with obesity, especially those involving the sex organs, the prostate, the breasts, the ovaries, etc. Let's see, and don't forget the joints, the wear and tear that occurs from being heavy, the spine, the knees, the hips, the ankles. You see a lot of people in our practice who are referred through because the orthopedist wants to replace their knees, and they have to get to a reasonable body mass index before it's safe to do the knee surgery. Let's see, and also gallstones. I see as the pediatric population became more overweight, I see a lot of children having to have the gallbladder removed. And also a big player that we need to address is fatty liver. Young people with elevated liver enzymes that can go on to cause inflammation in the liver, which then leads to cirrhosis and liver failure. And I mean, these things can be prevented. So this is why I got so passionate about treating obesity. There's so many things that can happen as a consequence, and what we want to do is intervene and help patients to handle this before we get to that point where you have cirrhosis and pseudotumor cerebri and no cartilage in your knees, et cetera, et cetera.
And Dr. Bryan, isn't it very common to hear patients express how because they have excess weight or because they can't seem to get their weight off, that they are just more depressed, more down in the dumps? And
Absolutely.
yeah, or even the opposite, right? They're really just stressed, because
Yeah.
it seems to just impact many components of their lives.
Yeah. And many times people use food to treat depression, as you're saying. Yeah, the opposite occurs. Absolutely.
And anxiety, right? Stress eating is real.
Right. Exactly. Absolutely. They like to ride together.
Yes. And it can influence sleep because what I've found with patients is when they are more stressed, they might stay up working later at night. And if they're not getting the 7 to 9 hours of sleep per night that's recommended for the average adult, then guess what happens? The body releases a hormone called ghrelin into the bloodstream. And if you have too much ghrelin in the bloodstream, then that causes the body the next day to just think, what can I eat? What can I eat? Even if you're not hungry, you just think, what can I eat? Because it triggers your brain to not be able to send signals to say, I'm full. Right? The way we turn off that kind of release of that excess ghrelin and allow more of a different hormone called leptin to be released, and that leptin hormone helps us feel full the next day, is by getting at least those 7 to 9 hours of sleep. So just a little sidebar there that
Which can be a problem in this country because we don't understand the importance, of sleep. In America, we feel like just keep working. I have so much to do that what we can sacrifice is sleep. Let's just get 3 or 4 hours and keep going.
Right.
And that definitely is a factor in weight gain.
So
Yes.
what I found interesting about what you were sharing, Dr. Bryan, and this slide is if we look at the organ systems that are highlighted, it's every organ system in the body.
Everyone.
So obesity impacts every organ system in the body.
Exactly.
It also impacts our emotional, our physical, our mental, and even spiritual well-being, right? I mean, how many times, do people, even question their own faith when they can't see the results they were hoping for? And so that's an area that many doctors don't delve into, but as an integrative doctor, that's an area I do tap into a little bit as well, because it's hard in the world of osteopathic medicine, which is more holistic, to get rid of disease unless you address the mind, the body, and the spirit. So, Dr. Bollie, there's the explanation. We address mind, body, and spirit on a more regular basis with patient and take a more preventative and holistic approach to our care. Next slide.
We have such a great discussion in the chat as well, or here. Dr. Jenny says again that obesity and the many diseases increase the risk for pregnancy complications, aka high maternal mortality. So that's great as well. And yeah, and so let's keep it rolling, because lots of reason why we need to know more and how to treat it is where people are also asking as well. So let's go ahead.
Great. Thank you so much for sharing that input. And if you have obesity, or if you know someone who has obesity, you probably have heard as well that if you get COVID-19 infection, guess what? You can possibly get a more severe form of it, which then can require hospitalization. And usually it's not just to a regular medical floor, it's oftentimes to an ICU. Which is the intensive care unit. And sometimes those persons who have obesity and COVID have to be put on ventilator machines. And sometimes they have a hard time coming off of it and have an increased risk of dying from COVID. If you will click your pointer. So all these things triple when you have obesity. But I share this nurse's perspective here, which is we can do this, right? You're here today. You attended this session today, and will hopefully attend additional webinars, because we want to do something about having excess weight so we can reduce the severity of COVID if we get it. We can heal and be well. We might not need to be hospitalized. And some of you might be able to attest to that, is you've been working on your health. You know, even if it wasn't just your weight, you've been working on being healthier. And if you had COVID, thank God you're here to attend today and live, tell, and be well. Next slide, please.
So, what is obesity? Obesity is defined as a chronic, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes an adipose tissue dysfunction and abnormal fat mass, physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. And that's how the Obesity Medicine Association is now defining obesity, a disease.
A lot of words, isn't it, Dr.
A lot of words. Hey, it's a disease.
But
Yeah.
each word is very important, you know,
Exactly.
and hopefully by the information we're sharing, our viewers will understand that when we're dealing with obesity, it's not acute. It's not like a cold. It's not something you just get from somebody else. Well, it is genetic, you know, but I mean, you know, you can't give it to somebody by sharing your respiratory droplets or, you know, something like that. So you can't get it from somebody else, and it's not going to last just 14 days like a cold.
Right.
We wish, right? We wish. And
And
we wish if it, you know, once it goes away, that it will stay away. But, you know, even if you have bariatric surgery, this thing called obesity, you know, this thing called excess weight can come back, right? That's why you and I are here, right, Dr. Bryan and Dr. Bollie?
Exactly. It does. People do tend to relapse. But I always say, stay in the fight. Don't ever give up.
That's right.
So, but there are many cases where people lose 100 pounds and then they may gain back, you know, some of that or all of it. And that's why it is a chronic disease. You don't ever stop treating it. You continue in your treatment with your bariatric or obesity medicine specialist. You stay with them, continue to follow up, and we can prevent some of that relapsing. That's what we're here for.
Thank you. Next slide.
Yeah.
Right. Yes, it's so true. All right, let's keep going.
Dr. Bryan, you forgot to do my lead-in.
Oh, I did. Yeah. That Dr. Nicholson has invited some special guests here today, y'all. Look who's joining us today.
Yeah, so I am so thrilled that these two gentlemen did not agree to attend, but they made themselves available to us online. And so here we have special guests, Mr. Brown from Tyler Perry's Medea movies. And I was calling the next young gentleman on the right side of the screen, Mr. Strong. And my sons, when they saw the picture, they're like, Mom, that's Ronnie Coleman, you know, he really is the strongest professional bodybuilder of all time, Mom. And then they went on to say, Mom, he was Mr. Olympia like 8 times, you know. So no, I didn't know. I just chose a picture of a very muscular person. But this is Mr. Ronnie Coleman. All right. And the reason we invited them, and I made up their ages. Of course, I did not make up that they're African American. I didn't make up their genders, but I did make up the weight, because it turns out when I did further reading, Ronnie Coleman actually is 5'11", and during his off season, his weight goes from 310 to 330, and during competition up to 300 pounds. Okay. But for the sake of today's presentation, we're going to say that each man is 225 pounds, 40 years old, African American, and male. So we made those things the same. So the question is then, who has obesity, right? And looking at Mr. Brown, he said, he does. It ain't me. But I want you to start thinking about the fact that excess body weight does not mean excess body fat. Next slide.
So I wonder who designs his clothing, huh? Mr. Ronnie.
Right.
He's obviously not going to buy his clothing from Nordstrom's.
Right.
Okay. So question number 3, you all.
At first, Dr. Bryan, we might want to pause, right, and see if Dr. Bollie has any questions we need to respond to.
You're right. Dr. Bollie, do we have anything? Did you have anything you want? Maybe she mentioned it before.
We're getting a lot of positive feedback. So you ladies are doing fabulous and with lots of engagement. I see a question here from Miss Elizabeth Mackey, who says, at what weight is an obesity person or a person with obesity from a child to an adult? So I guess she's asking about what are the kind of, how do we define it or determine it, which is where we're heading. So you all will answer that question very shortly.
Exactly.
And then, we have some star students who have already answered the question. They have already answered questions. So some star students here, we have nice. C, we have D, and people are answering the question already.
Great. So what is the question, Dr. Bryan?
So how is obesity measured? Do we just eyeball so letter A, eyeballing, just looking and saying, I think she's obese. No, I think she's obese. Or do we, by just pinching the love handles, everybody knows what a love handle is, around the waist there. C, by weighing on the scale, do we just say, okay, you're 150 pounds, you're obese? Or do we use the body mass index? And some people might already know what that is, and we're going to talk more about that. So in case you do know, you can, but we're not going to define it yet. We're going to wait until the next slide. So I'm just going to see how many people know already and can answer that question. So is it A, eyeballing, B, pinching the love handle, C, weighing on a scale, D, using the BMI or body mass index? How is obesity measured?
Have a lot of fast fingers here, and D seems to be the most popular answer.
All right, the answer
Smart
is D.
Group.
Yay!
Very smart group.
Good job, good job. So body mass index is the way that we currently use, what we use to measure whether or not a person is what you can also say over fat.
No, we don't say the F word. It's a bad word.
Has over fat cells is what I mean. Not as far as like a name calling, but over adipose. We can say it that way. All right. So BMI is the weight in kilograms divided by the height in meters squared, meaning height times height. So weight over height times height. And when you make that calculation, if the answer is between 18 and 24.9, you have a healthy body mass index. If that number falls between 25 and 29.9, you're probably overweight. And I'm going to say probably, and we'll talk about that in a minute. If the number falls above 30, that usually is classified as obesity. So we break that down into class 1, 30 to 34.9, class 2, 35 to 39.9, or class 3, 40 and above. which we also call severe obesity. So we have ways that we can make that easier by there are graphs you can find online, such as the one on the left corner. There also are calculators online that you can put in your numbers, click the NIH has a really good one. You just put in the numbers and you click calculate BMI, it gives you your number, and it gives you a little bit of information as well. And then there are the little hand tools like you see in the upper right hand, where you also use your height and weight, and it'll tell you where you fall.
So we have the chart, the wheel, and then we have the technology available, which is the online adult BMI calculator. And so the information you'll need to have available for that, when Dr. Bryan was referring to numbers, you must have your weight in pounds, and I think it converts into kilograms for you, as well as your height.
Yeah, you can do it either way. The NIH calculator, you have 2 tabs, and you can click using kilograms and meters, or using pounds and inches and feet and inches. So you can do it either way.
Yeah, and what I love about what you shared, Dr. Bryan, is you did not use the word morbid. You did not call one person who has a body mass index over 40 morbidly obese. That is actually incorrect terminology. I know it's still used in some diagnostic what do you call it, coding books,
Yeah.
but it is
Right.
offensive, and it is more reasonable to refer to over 40 as severe or extreme obesity versus morbidly obese. So that's part of what we call patient first language. And so it's really important to make sure that we do not say things in offensive ways when we're referring to people who have obesity. Next slide, please. So back to our special guest who has obesity, okay? We still haven't heard from you. When we eyeball each of these, just think about, who would you say has obesity, and why would you say they have obesity, right? When we made them, the same age, when we made them the same gender, when we made them the same weight, we really, to be honest, based upon the way that Dr. Bryan shared that we measure obesity, we still can't tell you who has obesity, right? Because all we had was a number from a scale. And that scale is just not smart enough to tell us how much of that weight is body fluid versus muscle mass versus bone mass versus fatty tissue. It's just not that smart. So we still don't know. We still need a height in order to figure out what the body mass index is. So in this case, we're going to say that Mr. Brown on the left in the blue, and by the way, he wore his fanciest to meet you today. He's 5'8". And we have Mr. Coleman on the right, who is 6'8" for the sake of this. So if they are the same weight but different heights, then let's see what the body mass index is for Mr. Coleman. Sylvia? Yeah, so it shows us, it spilled the beans already. Mr. Brown does have obesity. Why? Because his body mass index is over 30. And Dr. Bryan just shared with you that when the body mass index is over 30, then that does put you in the category of obesity. And because his is between 30 and 34.9, he's actually in obesity class 1. When we look at Mr. Coleman, his body mass index actually for the same weight, but because he's taller, he's in a healthy range for his body mass index at 24.5. So excess body weight does not mean excess body fat. Can you see that here?
Right.
Yeah, next slide, please. And so what we've learned is some of the limitations that we face when we are using the body mass index. So of course the FDA, NIH, a lot of people use the body mass index because it's the fastest and easiest tool to use, but it's not the most accurate, okay? We cannot use the chart, the wheel, the calculation at all for the pediatric group. There's a whole different curve that we use for them. We can't use it for the elderly, or shall I say, we use it, but we need more information in order to better understand how accurate it is for the elderly. As you could see with Mr. Brown, and I call him Mr. Strong, muscle mass matters, right? So athleticism, it does not take that into account. It does not take into account body composition, as I just mentioned. So if, say, for instance, you have, and I'm going to say it this way, more body fluid, say if you have heart failure, so you have swelling in your legs, or, you have liver failure, so swelling in your abdomen, then the body mass index doesn't take that into account. Or if, say, for instance, it's that time of month for some women, we tend to retain fluid more around that time of month. It doesn't take that into consideration. It doesn't take into consideration ethnicity, gender, pregnancy, or physical disabilities. And it took me a minute to think about, well, what do they mean physical disabilities, and what does that have to do with BMI? Well, we have to get an accurate weight and height. And what I have experienced in the clinical setting is sometimes patients have a hard time walking because of their knee pain, because their legs might be weak from back pain. And so it's hard for them to stand all the way up and give you an accurate height. And it's hard for them not to hold on to anything when they're trying to give you a weight. So that can cause the BMI to be off some. Next slide, please.
Yeah. And also as you said, body water, some retention will also affect those numbers too, leg edema, et cetera. Yeah. And so this this graphic is just a little snippet, a little hint at something that's going to come later in another presentation by, I believe, Dr. Bollie is presenting this in a separate presentation. But we just wanted to give you a little hint that there are some changes in how there are people looking at this and looking at the thresholds of what we're calling obesity, and maybe we should be modifying that. And for example, if you look at the circle, those in the circle, so maybe if a person has a comorbidity of hypertension, a Black person with hypertension, that maybe that their body mass index should be 31, should be where we consider the beginning or the threshold for obesity. And so I'm gonna let Dr. Bollie get more into that in her presentation, but just wanted to say that we are looking at, maybe this is not the body mass index may be old now, and we maybe need to look at this closer and modify what we consider as obesity.
Dr. Bryan, and what I failed to mention when I was talking about the body mass index is the Asian Pacific Americans already have a different body mass index chart that is accepted.
Yes, that's very true.
Now, why they didn't do it for other ethnicities, I don't know. But it's good to see that now this information is starting to be generated. These studies are being done. And I just say stay tuned, because the hope would be that we can have something that is more representative and accurate for different
of where we are right now.
Yeah. Next slide, please. Thank you.
Yeah, I can't wait to share that. So in our, I'm biting my tongue. This is y'all's show, so I'm not saying anything.
You were almost bending in your chair there.
I know. Okay, go ahead, dear. Okay.
We come back to who has obesity, right? And we're sharing different scenarios. So in this scenario, they're still 40 years old, still both African-American men, still both the same weight, but now we've made them the same height. So what does that look like? Now it looks like they both have obesity, right? Because their body mass indices are 34.2. So they both have obesity based upon the body mass index, which now means Mr. Strong, although he looks fit as can be, is being categorized as having obesity and being unhealthy. So we present this scenario because it's important that we don't just look at the scale. We don't just look at the body mass index. There are other diagnostic tools that we have to consider in order to truly assess obesity. Next slide, please.
Yeah, his body fat's clearly about 0.
Yeah, yeah. And just stay there for one moment. Let me share this with you. So I'm going to tell you on this next slide about waist circumference. So if you can find Mr. Brown's belly button, and I believe it's right there where that button actually is, and if you can find the belly button of Mr. Strong, we would measure around the body at that level of the belly button and have the individual take a deep breath in. And when they exhale, at the end of exhalation, so you can't like suck your gut in to get this waist measurement. At the end of exhalation is where we get the measure. Right. So thank you. You're correct, Sylvie. Advance, please. So other diagnostic tools that we use to assess obesity are metabolic history and labs, right? And this helps us to determine the causes, symptoms, assess severity, guide treatment, but also once we start treatment, by further evaluating labs again, it tells us about progress. How are we doing? Are the medical conditions that the patient had improving as the weight is improving? We use a scale, number 2, and that was the first thing we mentioned, to get a weight. We use body mass index to get the weight and the height and generate that number that then not only will tell us whether or not a person has overweight or obesity, but it will also guide our therapy. We'll see in a few. Body fat composition using the handheld device, or there's a device that you can stand on. And that also helps us to determine if a person has an unhealthy amount of fatty tissue in the body or a healthy amount. And for women, 30% or more is going to be unhealthy, and 25% or more is unhealthy for men. So when we get to the waist circumference, as we already mentioned, you're going to use the tape measure. It does estimate visceral fat and central obesity. So visceral fat, many of you probably know, is that fat that you can't touch, right? You can poke yourself and touch what we consider subcutaneous fat. And that comprises about 90% of our body. But 10% of our fatty tissue is directly around different organs in the body. And if you have too much fat around these organs, then that increases your risk for developing other chronic diseases. And that's what the waist circumference gives us a good idea about. It's your increased risk for weight-related chronic disease if it is out of range. And out of range for women is 35 inches or higher. Now, while we didn't get the higher number here, I think there must not have been any women on the committees that came up with these numbers. Yeah. But, because men, they get 40 inches, but we all know men can lose weight faster in the belly than seemingly women do. We got to carry babies and all that for 9 months. But nonetheless, the numbers that we use are listed there. Next chart, please.
So, and even with that, I should just say, add there, we'll talk about in the next presentation, there's some newer data coming out for Black women that those numbers might even be low in terms of waist circumference for our risk of metabolic health diseases and insulin resistance. So stay tuned, because we'll really get into it in the details in next.
Yes.
Dr. Bollie, we also might want to mention, we were talking about alcohol consumption earlier. Beer belly is real, right? Mm-hmm. So what we understand about alcohol consumption is when you have more alcohol that you consume, it can increase that visceral abdominal tissue, or the visceral fat, the belly fat, make you more apple-shaped. And if you're apple-shaped, then that does mean that but because of your genetics and maybe even behaviors, that you are at increased risk for developing some of those diseases. The other thing that happens is when women start to go through menopause and estrogen decreases, weight increases. Okay. And as the and in some instances, and then there are other instances where the weight does not increase, but the abdominal girth there does still increase, and that is has a lot to do with the reduction in the estrogen as well.
Exactly. And Dr. Jenny has said testosterone is a muscle builder. Estrogen is a fat storage hormone. So yes, no fair to the waistline that. And that's true. And actually, Dr. Jenny, to that point, again, that's why we're starting to see there are some studies that show that also we tend to have more subcutaneous fat, which is not the same. So it's fat under the skin, which is not the same as visceral fat, which is that around the organs. And so that's also why that may be less accurate as well for women. So it all is kind of driving towards what we're going to talk about, which is why we need to personalize these measurements. We have these big generalizations, but personalizing will be helpful. So, all right, ladies, I'll let you keep going.
Okay, so the good news, switch to the next screen, please. There are some predictors of good overall health and good mental health. So some of this is pretty obvious: eating healthy portions of fruits and vegetables and lean meats, et cetera, et cetera. Being a college graduate, usually the income is going to be higher. You'll be able to afford that gym time. And also you'll work, your life is just tends to be, well, many times a little less stressful. Never smoking, obviously. Smoking is a big factor. Having no major health conditions such as cancer, diabetes, heart disease, etc. And something that's definitely not for the majority population, but for us, fewer experiences of everyday racism and discrimination. That's a huge mental stressor. And you experience something called angst when you're in a situation where there's not something you can do about it and you're just stressed about it. And that leads to the higher cortisol levels, which leads to weight gain and more and other problems as a consequence of that. So having fewer experiences like that, just having a more peaceful existence on your job and in your life improves your good overall health. Fewer caregiving responsibilities, which is a huge mental stressor when you do have those caregiving responsibilities. And I can tell you, a lot of us are in that situation. You have your parents, you're caregiving, your children, you're caregiving, maybe there's a spouse who's ill. And Black women tend to fall into that a lot. So with that not being a factor in your life, we seem overall to have better health. Lower body mass index, and we just finished talking about that. Income more than 100,000, which usually correlates with those who are college graduates, but not all. There are people who do things that don't have anything to do with being a college graduate, and they do very well. So I don't want to come across as if you don't go to college, you're not going to be wealthy. That is absolutely not the case. And brisk walking is a big factor in improving your health, mental health, as well as physical health. And I saved the being single part because I just had to laugh at that when I saw it. We read often, and when we're talking about men, that they do better, they live longer, they're healthier when they are married. So it's interesting to me when we have results like this, that women being single have better mental health and it's a better overall health predictor. So I don't know what that means. We gotta take it and
Brian, you told me you thought it was because, especially for people who might have gone through difficult marriages, they got rid of their stress when they went through the divorce.
Yeah. If they know what I know with my ex-husband, I can definitely say I won't go there. Anyway, moving right along to the next slide.
Okay, next slide. And Dr. Jenny asked a great question. How do you start the sensitive conversation? I think we'll keep that for the end because that's a great way, I think, to end the conversation. So let's keep going.
Okay. So in these areas of the country, the Black Women's Health Study showed that in Detroit, that an important factor for good or excellent mental health was brisk walking. In Washington, D.C., religion and spirituality seem to be an important factor. And in Atlanta, education, maybe it's because Morehouse and Spelman are there, I don't know. And Los Angeles and Riverside, brisk walking and education were important factors.
And these slides, go ahead, Dr. Nicholson.
No, after you, Bollie.
Oh, no, I was just saying that the reason why we included these slides is because it really is more than calories in versus calories out. And that body, mind, spirit connection that we've been talking about is so important, because when we talk about weight, when we talk about obesity, there are a lot of things that weigh on you that go beyond just what's on your plate or how you're moving. And so I think this, which is one of the largest and longest ongoing study for Black women in the United States, point that there are other key things that it affect our health other than that. But go ahead, Dr. Nicholson.
And, and also I wanted to point out that Index's study, as a result of this slide, I went and looked for that study, and I wanted to, oh, here it is. I just wanted to suggest that the group read that study. It was very interesting. Indexes what healthy Black women can teach us about health. Black women's health imperative. And I just Googled it, and it's easy to find, very colorful, easy read, but it has a lot of good information in it. So I just want to suggest that to everyone, take a look at that study.
And you kind of paused a little bit when you were mentioning about reduced stress. I think I had a little thought about that. I think perhaps the mental health improves because patients are most likely sleeping better, right? When their body mass indexes are better, because they're probably having more energy to do the brisk walking or to have some form of physical activity, which also promotes a mental wellness. And so I think it might not even be that the stressors in life changed, but it could just be that they were better rested and they were in a better position to respond to the stress better.
That's true.
But just a thought. I mean, I did not read the study yet, but that's just a thought based upon my clinical experience.
The chicken and the egg, which came first, the improved mental health or the weight loss? And I think we all could have conversations both ways with it, right?
Exactly.
All right. So what is our question? Go ahead.
Yeah, so we're in the purple slide. Purple slide, please.
Okay, purple slide.
Yeah, so do we have any questions in our Q&A section?
We have some great questions, but I'm thinking in the interest of time, we should try to get through the slides and then answer all the questions at the end. So we have, how do you begin the sensitive conversation? How do you incorporate obesity care and awareness in your current practice? So those are great questions. Do you want to answer them now? I'm thinking let's get through the slides, and then since we're coming up on 7:30.
Yes, we just have a couple of slides. So if we can answer this question 4, what is the best treatment for obesity? Is it to eat less, move more? Is it B, lifestyle modifications such as get proper rest, de-stress, stay hydrated, reduce sugar sweetened beverages? Is it C, take prescription weight loss and hormonal medications? Is it D, get bariatric surgery? Or is it E, all the above according to BMI? Dr. Bryan, I was missing your Jeopardy music. I thought you were going to do that tonight.
Oh, I did do that.
Ooh, guess what, y'all? Controversy already. Okay, B is the most common answer so far.
Great. So the question is, what is the best treatment for obesity, right? And don't forget, when we're using multiple choice questions, the goal is to choose the best answer. And so although each of these is correct, the best answer is E, all of the above according to BMI. Next slide, please, before I get tomatoes thrown at me.
I know, everyone was B. Whoa. Oh my gosh, we got work to do, y'all. Everyone needs to keep coming to the series. Yeah. Okay.
Yeah.
Yes.
So this is why D is the best response, because in order to have a starting point with patients in first of all, assessing whether or not they have a healthy weight or unhealthy weight, we have to establish the body mass index. And then once we do, if it's 18.5 to 24.9, then we give them a big applaud and say, well done, you are at a healthy weight. Let's just see what we need to do to continue you on course of preventing weight gain, but also staying healthy, right? If it's 25 to 29.9, That's unhealthy. That is the overweight category. And guess what? This is where we start with lifestyle modifications, which includes things like nutritional counseling, physical activity, behavioral counseling. And when we talk about behavioral health, that includes things like sleep health, substance use, stress management, mental health. So all of that is like our first line of defense when we're trying to address excess weight. Okay, so if a patient's in the overweight category, we start there, right? We did not say medications. Why? Because medications in general are not covered by insurances unless the body mass index is over 30, or if the patient has a body mass index of 27 plus one or two other medical conditions that are associated with their weight. But the magical number for medications is 30. So when it's 30, we have several medications. And years ago, it was just the Phentermin and medicines like Phentermin, and that's been out since the 1950s. But now, and that was for short-term use, meaning you can use it for up to about 3 consecutive months of use. And of course, some people use it longer than that, but per guidelines, that's kind of where that is. Long-term medications are some of the newer ones, like your Phentermin and topiramate combination, also known as Qsymia, or your Wellbutrin and naltrexone combination, also known as Contrave. And then one that's been around for a while is Orlistat. We call it Orlisplat, meaning when you take that one, it can cause a little greasy rear end kind of experience. So it's not as well liked as some of the others or as effective even. But now we also have injectables, and that's why I have the picture. I was not trying to promote Wegovy, but I just wanted to give you an idea that we do have injectables. So that means you don't have to take pills if you would like to try a medication. You can, if you qualify for it based upon guidelines, and if it's affordable enough, you can take a once a day injectable called Saxenda, or a once a week injectable called Wegovy, and those just came out over the past couple of years. I mentioned Plenity by name because it's not listed as a medication for weight loss. It is listed as a medical device for weight loss, and that's where you take 3 pills before lunch, 3 pills before dinner, with a full 16-ounce glass of water, and it expands in the stomach, almost like, have you all seen those little animals that are sponges and they're in the capsules, and then when you put them in water they expand into the animal? So it's similar to that. These little beads, cellulose beads, expand in the belly, take up about 2/3 of the belly, and are supposed to help you feel full faster because of that. So that's considered a medical device, which is why I included it as a picture. Now when we get to a body mass index of over 40, that is considered severe obesity, and that's where you can potentially qualify for bariatric surgery, the most common being gastric bypass, gastric sleeve, and gastric band. Although I will say a lot of surgeons prefer not to do the gastric band because it has not had the success that we hoped it would have, and they are now finding it can cause some complications, causing them to have another surgery to remove the band and potentially perform something like a gastric bypass. Next slide, please.
Next slide.
I'm trying. Thank you.
Oh, I see. I'm sorry. So our goals for obesity. The main point of this slide is to get the understanding that what we use as a goal is we want our patients to achieve the lowest weight you can comfortably maintain. It doesn't do you any good to lose 100 pounds and then gain back 150 or even 80. So the goal is to get your weight down and maintain that weight loss. And wherever you can, if a 75-year-old is not likely they're going to get their body mass index down to 24 if they're starting at 40. It's not likely. If they get it down, it's not likely that they're going to be able to do the exercise and things that will be required in order to keep that weight off, because our body does have a way of trying to stimulate more hunger. Physiologically, there are changes that your body is trying to get your weight back to where it was. And so there's a bit of a battle that goes on once you've lost weight. The metabolism slows, your stomach begins to make more ghrelin, and the hunger increases. So there are some things that are real that are happening in a person when they have gone through a process of losing weight. So maintaining that weight loss is difficult. So we want to stress that if you lose even 5 to 10% of your total body weight and maintain that loss, you have made a huge advance towards improving your health. Or to lose 1 to 2 pounds per week, that's a reasonable goal for weight loss, and to reduce your body mass index by 2 units. To achieve that, it may not sound a lot when you are 100 pounds overweight. It's not the ideal body weight, but it does improve your blood pressure. It does improve the blood sugar. It does improve your overall metabolic status. So it improves your health to even lose 5 to 10% of the total body weight.
Last slide, please. So we end where we began, and that is sharing that obesity is a complex neurobehavioral, chronic, relapsing medical condition, not just a lifestyle choice or a cosmetic concern.
Yeah, there are many contributing factors to people having obesity and to Black people having higher rates of obesity.
And the diagnosis of obesity goes beyond the body mass index.
There's no cure for obesity, but multiple treatment options are available beyond lifestyle modifications such as diet and exercise. So an individualized, comprehensive approach for both prevention and treatment are necessary. Very important.
And you don't have to lose 30 pounds in a month, right? 30 pounds in 30 days. If you can just get 5 to 10% of your weight off in a 6 to 12 month period, or lose 1 to 2 pounds per week, then this can improve obesity and all those 236 conditions that are associated with it, as well as your quality of life, and add great years of life.
Amen.
Next slide.
That's such a great point.
Yeah. So obesity is a medical disease. This is what we really want to make that point. This is a disease. After all these slides, we hope that we've made that point.
And there is treatment for it, and we hope that you hear that. But we thank you for your attention. We know we are a little past the time, about 5 minutes over, but Dr. Bollie, we turn it over to you, and we're open to any questions.
Yes. Well, first of all, big round of applause. I think the audience out there, even though you can't see them, you can't hear them, I will clap loud and clear for them because you ladies did a phenomenal job. Phenomenal. So thank you so much. And there are so many wonderful questions in the chat. And so if it's okay, Tashi, because she handles the logistics, can we just answer those questions in about 5 minutes or so?
Yes.
Okay, awesome. But thank you again for just driving home several points. And this is why we're having this series, because you really helped to bust a lot of myths. And so, Sandra Guzman says, thank you. Annette Bramble says, thank you. So thank you. Okay, so let's go back and get some of these questions answered. So, and if I miss your question, just let me know. So there's a lengthy comment here. It says, this is so good, but it needs to be broken down from age groups, from children to adults, because my daughter, when she was young, she had obesity, not because of healthy eating, but because her grandmother not from my eating at home, but because her grandmother, the school, and it became a case in point of what was going on. So I had to take her to her primary care nutritionist to have a conversation with her grandmother in school. She was diagnosed with prediabetes, so she didn't know what was going on. Then therapy had to be in place. Nevertheless, I had to explain in words that a doctor stated that the meaning obesity was overweight because of the fat cells were not dissolving fast and because of a lack of exercise. So I repeated to her and she stated she would call her fat, but all I was telling her was that the doctor said she is 25 now, but continues to bring up the time that said I was fat. The mental was not there because I work so much. So again, I think this is a very touching story that just drives the complexity of this disease of obesity, and that there's so many factors both that you can control and that you can't control, and you can try to do some things, but then there's other influences. And you're right, we focused a lot on adult obesity, but childhood obesity is a very complex topic in and of itself, and probably its own webinar for that as well.
Yeah, and let me just say that when we talk about obesity, one of the things that children especially are affected by is that it feels like you're name calling and not or criticizing when we talk about it in a medical examination. And we as doctors, and I know there's some on the line, we have to be very careful about how we approach to having that conversation, and to come across as, let's talk about your health, and not, as an observation that you're fat. But we're not talking about how you look. And the goal is not to, look like obese, like Beyonce. Our goal is to not have a heart attack. And so it is a very sensitive subject, especially with children, because kids can be so mean in school, and that child may be getting bullied. So, I think that's a big, there's a lot involved in all of that does need to be addressed. And a behavior specialist is very important in this process of obesity treatment, for children as well as for adults. A behaviorist is an important piece of the treatment team. I think there was something else I wanted to say. I'm sorry, I lost track. I'm just seeing this little girl and all, I can just see it, because I did, as a part of what I did at VCU, was create an adolescent obesity treatment program. And so I dealt with this a lot, in the kids would just look so defeated when we were having that conversation. And I just had to, really look them eye to eye and say, look, I really don't want you to feel like that. Like, this is, like, I'm criticizing you, but we're trying, what we are doing is addressing a health issue, and we're trying to make you healthy. And that's what we're doing here. It's not, everybody's not going to look the same, and it's not about that.
I would piggyback on that, Dr. Bryan, and say it's important too for the parents to protect your kids, right? Let it start with you, though. Don't call your kids fat names. Like, I know, there's some kids that they're like the cartoon Fat Albert. Okay, I know some kids whose names are like, I'm going to say Fat Mike. So if people are calling your kid fat this, fat that, fat is a forbidden word in my household. Okay, I mean, you can talk about fatty tissue on a chicken, but you better not be calling somebody else fat. So I think it's important to start working with your kids too. Don't pick on people because of their size or how they look. And, in my household, it's a little different. My kids are athletes, and they have wanted to gain weight because they're thinly framed, and they feel like in order to be better at some of the sports like football, they need to be heavier. But anyway, be careful not to call people fat. Be careful when you see them not to comment about, girl, look like you done put on some pounds. Be careful not to go up to them and pinch their waist. That's offensive. If you're not going to say anything positive, just don't say anything at all, because it can traumatize kids through their adult years. And if you have done it to someone, guess what? It starts with an apology. Just apologize and let them know that after attending our talk today, you have a better awareness and you understand your faulty thinking and approach.
And let me just say one more thing about that situation, and also in other adults as well as kids. If there's someone else cooking, like grandma, bring them to the office. They need to come in. They need to have that discussion, be involved in the discussion about the changes that need to be made. They need to be a part of the treatment process. So grandma needs to come into the office, or if the husband cooks or the wife cooks and you're treating the husband, they need to come in. They need to be a part of the discussion.
It's a team, very comprehensive approach.
Yes.
Absolutely. I love that. I mean, because honestly, those childhood scars do not go away. They stay. And a lot of the work that we do in practice has a childhood source. I see so much there's a thing, I think Dr. Jenny or one of the other people asked if we would talk about trauma, and we will, but I know in my practice, I routinely use something called the ACE, or the Adverse Childhood Event Scoring System, because that was actually developed in a weight management clinic, and the number of adverse childhood effects, which some of them are just verbal abuse, were you bullied, that like some of the questions are that at the more of that, the higher your score, the more likely you are to develop obesity, but not only to develop it, but also be unable to successfully keep the weight off or be at higher risk of relapse. So these things don't go away in adulthood without treatment, without intervention. And that treatment is not just physical, lose weight, drop a couple pounds, it's also psychological and even spiritual as well. So I'm glad we're talking about it, and we'll continue talking about it in the personalized. And that kind of answers one of the questions. Dr. Jenny asks, how do you start the sensitive conversation? And for me, it's always asking permission. May I speak about this? May I talk about that? I think that's the first place, because you need to assess where people are if they're ready to change. I'm not sure what you all do in your...
Yes, I agree with that. And that is recommended by the OMA.
Nice.
Well,
I guess.
Huh?
I guess I'm not so nice. But because the approach that I take, to be honest, by the time they come into our weight management center, they already know
Yeah,
they
that's
have a
different.
well,
That's
a little
different.
different population. Yeah,
right?
that's a
But
different.
even when I was in my family practice, integrating it into that, the way that I approached it was, I talked about it like a vital sign, right? Because this is life or death. So by the time I talk about the blood pressure, the heart rate, the oxygen level for the day, temperature, and I give them kudos. And then we get to the weight and the height. I said, and then a number known as your body mass index is generated. And based upon your body mass index today, it does put you in the overweight category, or today it does put you in the obesity category. And then I might ask permission if we can talk a little bit more about that, because when your body mass index is high, it does put you at risk for this, and that. So let's talk about how we can prevent those things. So I take a more preventative approach once we establish, well, where are you? What do your numbers mean? And what do we need to do to improve?
Got you. Yeah. And I think that's helpful, the normalization of it, right? That's the nerdy medical way that we would call it, like normalizing that this is just a part of your vital signs. And that's what we're talking. I'm not judging you, and coming at it from a non-judgmental approach. I think, I just did this talk and at the Obesity Medicine Association. And that was one of the most common questions. How do I even have it? Because if they're coming in for something else, and then you have that conversation, also in another venue in the Overcoming Obesity Clubhouse, which is more public facing, people ask, well, how do I talk to a family member? How do I talk to a loved one about their weight changes? And I think for me, it always is, well, what's going on in your life? Because weight is a symptom. It's a symptom. It is a symptom of what's going on. We even say obesity is a disease, right? But that's the disease, but the weight is just one part of the disease. There's so many other hormonal things going on. So I think being sensitive to it can be very important, especially, but not avoiding it, which is, to your point, Dr. Nicholson, is so important.
You need to have that
Just
discussion.
at least plant the seed, right? You don't even have to get the discussion in that visit, but at least acknowledge that this body mass index today is either in a healthy place or it's in an unhealthy place. And you can even say, you let me know when you're ready to talk more about this. But there are things that we can do, and there are conversations we can have, to get this to a better place. So whenever you're ready, I'm here.
I like that. Yeah, it's a process, because it didn't happen overnight, and it doesn't have to happen in one visit.
Exactly.
And then, so how do you incorporate obesity care and awareness in your current practice? Now, Dr. Jenny, we are all members of the Obesity Medicine Association. So I was like, that's a lengthy answer, really. That is a lengthy answer. I'll let these ladies take a stab at it first, because I have a lot to say over there. So go ahead.
I start with the vital signs, and just opening the door, increasing the awareness. And then that offers opportunity to increase education about, what our resources might be. Because say, for instance, if you are the healthcare provider and you're not comfortable talking about this disease yet, then having the awareness of who are your resources in the community, right? Who are the obesity specialists in the community that are board certified? Because just because there's a weight loss medication over the counter or an herbal herbal remedy over the counter, or there's a weight loss clinic, but it's not a board certified person, although they are seeing results. It's like, but are they safe? You have to kind of be aware of what your resources are in your community and who you can tap into. But I would encourage you to at least tap into the Obesity Medicine Association. There's a directory, and look first for those members who are board certified in obesity medicine. Excellent resource until you're able to attend more conferences and feel more comfortable addressing it in the practice. And I'm happy to talk off camera.
That's what yeah, you can reach out to any of us offline too, because we need more people in all fields who are addressing obesity. So we appreciate your interest, your zeal, because honestly, that's how it started for each of us. So Dr. Bryan and Dr. Nicholson, we were all in a health system working together. I got interested during my own personal weight loss journey. And that's when I realized, well, everything I learned in med school about weight, obesity was wrong. And then that's how I kind of stumbled into learning about the Obesity Medicine Association. Went to my first Fundamentals of Obesity course in 2015. And then from there, just got boarded and everything like that. But we really, because obesity was just recognized as a disease in 2013, many of us did not learn. And I still do work with the medical school now, and they're not learning it in depth either, because there's so much. So if you're interested, please reach out to us, and we'd be happy to point you into more resources. I wrote a book. There's other great books out there, so we can help you get connected.
And if you want to learn more about the barriers to accessing medical care, I am presenting a webinar with Robart Corporation. I believe it's August 26th. So feel
25th.
25th. Feel free to sign up and just listen. It will share some perspective about the barriers and what we can do there.
Yeah. Well, the funny thing about how do you address it, when you think about obesity is a part of so many of things, like we mentioned, all the many disease processes that obesity is linked to. So if you're an orthopedist, you're going to be addressing obesity. If you're a cardiologist, you're going to be addressing obesity. It's a part of everything. So,
but the challenge, Dr. Bryan, is the way that it's currently being addressed as you take a sip of water there is patients are being told you need to lose weight if you want to have the surgery. So they're being told, put the fork down. They're being told, push back from the table. They're being told, exercise more and eat less. They're being told, I need you to lose 50 pounds in 2 months. So unfortunately, there still is a lot of education that our peers are going to need. So it's important for us to continue to share knowledge. And that's why it's so awesome that, Dr. Zamora is here with us this evening, YN and many other things. And I'm sure we have others who are in the medical profession. We thank you for attending, both those colleagues and everyone else who has come out this evening. Thank you. We hope you have learned something new today. We hope that we have sparked a new excitement to share the knowledge, but not only with family members, but maybe even with your healthcare professional. And, at some point, if you have a testimony where you once were on more medications, where you once felt poorly, where you once had a higher body mass index and excess body fat, and body weight, but you are no longer there. Tell your story. It will certainly encourage somebody else and help them to know that they can do it too. So we applaud you for that, and we invite you to continue to share your story, and kudos.
Yes, I second. Absolutely.
And people have asked for contact information. You're certainly welcome to drop it here. We will be sending out information after the webinar that has the contact information from all the speakers and the panelists. Some things coming down the pipeline. We're working on a resource list for the Black Health website, and that will have all the panelists' information as well, and how to connect with them, as well as different resources that you can use to empower you on your body, mind, spirit, obesity journey as well. And so I also want to make you aware of the upcoming webinars. So we've alluded to some of them also. So next The next one coming on August 18th will be in the afternoon. It's the only one in the afternoon from 1 p.m. to 2:30 p.m. Eastern Standard Time. And it's patient perspectives and personalized obesity care for Black women. We will be going in detail, going beyond the BMI. What are some other tools that we can use? We'll talk a lot more about the race and ethnicity. We'll talk about the role of trauma, mental health care, and really how to personalize. Someone asked in the comments, so do I start with mental health? Not necessarily. It really depends on what that individual needs and what's the source, what's the primary triggers for their obesity. So we'll be talking about how to identify that and get in, figure out your triggers as well. And then we can't leave the men out, and we can't leave our LGBTQ community out. So we'll also be including them throughout the discussion as well. Men will be on August 30th from 6 p.m. to 7:30 p.m. And then we'll wrap up. One key thing that was alluded to in this talk, but we didn't really highlight, is the role of weight bias, the discrimination against people based on their weight, whether it be underweight or whether they be overweight. Of course, we see it a lot more in people with obesity. So we will have a whole discussion around weight bias and also the intersection that it has with racial and gender bias as well, and some of the policies that are coming out that will help with that also. So lots to come. We are so grateful that you're here for our inaugural webinar. Dr. Nicholson and Dr. Bryan, I knew these pioneers in the field of bariatric medicine would be the perfect foundation, and they did not disappoint. They brought it. And so thank you very much once again. Thank you to Black Health for putting on this very, very important discussion, conversation, and all the work that you do to improve Black health in the community. And thank you to everyone for being here tonight. And we pray that, again, that you leave with one thing. We know we talked about a lot, but just start with that one small thing that can change your life. That one small thing, the easiest thing even, and use that and start from there. So with that said, I'll turn it back over to Tashi from Black Health, and we'll conclude our program. Oh, Tashi, are you there? Okay, she has a survey that she also wants you to take.
I'm here. I'm trying to get back on.
Okay, thank you.
But yes, if you all haven't already, please take the survey via SurveyMonkey for us, just so that we can know how you feel about these topics. Just get a better idea of the type of programming we're gonna have, or we're gonna continue at Black Health. So please, if you have not already, take that survey before you all leave. And thank you. Thank you for coming.
Thank you. Thank you.
Okay. Well, thank you everyone for having me. All right. Have a good evening.